So good evening, everyone. Today's topic of mine is transseptal puncture of left atrial appendage closure. So left atrial appendage closure has reached its journey starting from the 1950s when we started puncturing the interatrial septum just to measure the left atrial pressure before we have done the MVR, that is the mitral valve replacement or any kind of surgical procedures. But nowadays it has expanded its arms, that is the transseptal puncture is needed starting from the electrophysiology study to the appendage closure to left ventricular assist device placement and the most important, the PFO closures. And these days, the mitra clip as well as the transseptal repair of the prosthetic valve leaks through the plugs. So we all know how does the left atrial appendage occlusion helps us to prevent the thromboembolism, because it is the only cul-de-sac that is responsible for the thromboembolism starting from the left atrium to the left atrial appendage. It is the most important structure that generates the clot within the left atrium. So we can basically skip the VK, those patients who are not willing or not be able to cooperate with the PTINR maintenance, and the oral anticoagulant therapy is not suitable to them. Early CKD or in advanced stages or in patients with cancer chemotherapies, in those patients definitely it is a reasonable approach to all of them, and it is possible by implantation of the occlusion devices through the percutaneous approach or through the other approach, both surgical as well as percutaneous, that I shall be discussing in my later slides. So starting from several devices, before the devices starts, we should know the left atrial appendage anatomy. So it consists of most of the cases two lobes. Almost 40 to 50% of the left atrial appendage consists of two lobes. It may be unilobe or multi-lobe, that is 2, 3 or 4 lobes, but most of the cases it consists of two lobes. And the anatomy, mostly the chicken wing, followed by the cactus, and the other windsock abnormalities or variants are there. So we have several devices in our armamentarium in our hands, starting from the Watchman Boston device, and the most important these days is the Watchman FLX device. So what these two devices differs? If we go with the Watchman device, it consists of 10 struts, and the Watchman FLX is a compact structure consisting of 18 struts, which tightly negotiated within the left atrial appendage. And most important thing, it is recapturable. We can recapture it if it is not positioned within the left atrial appendage, and we can replace it again. Abbott started its journey with the ACP, that is Amplager cardiac plug, followed by the Amulet device. Amulet is extensively stable, and I have experience of using this Amulet device at least 3 or 4 patients, and they are quite stable after implantation of this Amulet Abbott device. So before going to the anatomy proper, the left atrial appendage occlusion, it not only prevents the thromboembolism in atrial fibrillation, but also helps us in preventing the prescription of long-term maintenance as well as the window period of VK. We all know, but it is most likely to prevent the bleeding score as well. Those patients who are not able to take those high-risk NUACs, or preferably in patients with the non-valvular AF or in patients with valvular component also, if the PTINR window period is not maintained. So the growing evidence with these devices, both the Watchman as well as the Amplager devices, resulted in several guidelines, and it has recommended as a class 2B recommendation for the left atrial appendage closure in patients, those who are having contraindication of anticoagulation, be it a VK or NUACs. And the Amulet, what we are fond of, is the second generation Amplager LA appendage closure device compared to the ACP. The Amulet device has more anchoring hooks, as I have already discussed, and it is almost having a stability in the left atrial appendage. So without wasting much time, straight away I shall go to the anatomy proper. I have already discussed it consists of several anatomical variants like windsock, cactus, chicken wing. Chicken wing is the most important, most common one. So most of us perhaps be familiar with the thing that the left atrial interatrial septum, generally we do it with the Mullins sheath as the PTMC procedure and through the radiographic approach. So the needle most often used as a stainless steel needle, the broken borough needle, which is the most commonly used in Medtronic ink with the and the needle is hollow tube, which is 18 gauge tapering with a 21 gauge needle. But it is preferred go with the St. Jude BRK standard needle in case of left atrial appendage, because it has two things. Number one, if we use the BRK needle, it has an angulation of 19 degree, and if we have a large left atrium, we can shift to the BRK1 needle that has an tip to shaft angulation of 53 degree. So larger right atrium, it is always preferred to go with the BRK1 needle that sits in the interatrial septum, and it's easier to puncture the interatrial septum in the proper place. So we should always know where to puncture for this placement of the left atrial appendage closure device. It is the inferior and the posterior part of the left atrial fossa ovalis, and through this needle, it is easier to puncture. If you can see, there are various angulations here with the BRK devices. BRK normal has a short angulation, and BRK1 has a almost 60 degree, near about 50 to 55 degree angulation, which are we feel generally comfortable to go with these devices. After the puncture, we generally advances the Mullin sheath, and generally it is done at the 4 to 5 o'clock position to have the appropriate position, as we are doing in the PTMC or any other procedure in the intra-atrial septal puncture. The left atrial entry is confirmed by the reddish blood of the left atrium, and obviously the pressure tracing in the left atrium, it is important. But before going to puncture in the 4 or 5 o'clock position, the optimal position of the needle is to be confirmed by the RAO and the LAO view that I shall be discussing. Approach, we generally drop the needle down from the SBC, and obviously we put a pigtail for the safety profile. And after the second drop, that is from the SBC to RA and the RA to fossa ovalis, which is the common situation we generally are familiar with, we generally puncture the needle, the broken burrow or BRK needle accordingly, to have a safety, not to puncture the aorta or any other sandwich effect. So after the puncture, generally the inferior and the posterior puncture is needed, because it is the straighter approach to reach the left atrial appendage. If we do it higher, the sheath may be kinked. If we do it lower, we may not reach the left atrial appendage properly. So the appropriate puncture is extensively important. As we all know, if we go through the anatomy of the left atrial appendage, the most important thing to exclude the left atrial appendage clot before we go to the left atrial puncture. Because suppose we have punctured and I have put the wire and I have put the sheath in the left atrial appendage without knowing it contains of clot, so I may dislodge the clot and it consists of immediate thromboembolism. So two things is mandatory. Number one, to exclude through the TEE or transthoracic if we can able, and preferably in the TEE, that is the transesophageal approach, to exclude the clot. And the most important thing is the pericardial space evaluation is mandatory, because a chink of pericardial effusion, and if I go from the right atrium to the left atrium through a pericardium, the sandwich phenomenon, and ultimately may lead to the pericardial effusion, huge pericardial effusion, which may not be reversible. And the most important thing, the assessment of the length of the mitral valve to the ratio, which I shall be discussing in my later slides, and the closer relation of the left circumflex artery, because it is the most approximate and the closer position from the left atrial appendage. So these are the closer anatomies. The left atrial appendage through the transesophageal approach, generally we evaluate in the upper esophageal at the 0 degree view. So if I analyze this picture, the left atrium to left atrial appendage generally is straight unless and until it is a cactus or the chicken wing, and it is closer to the left upper pulmonary vein. So it is always easier to put your sheath or wire first in the left upper pulmonary vein, then drop it down to the left atrium. You may inject a few amount of contrast media to confirm your position, whether it is in the left upper pulmonary vein or in the left atrial appendage. Then definitely wiring is important, and gradual progression of the sheath to the left atrial appendage up to 10 to 12 millimeter advancement, because the placement of the left atrial, whether it is the Amplager plug or the Watchman device, the length assessment is important, where I should release the device. Because to release the device, it is generally recommended that 10 to 12 millimeter gap from the ostium, that means the LA ridge to the left atrial appendage is generally necessary. And it is close to two things. Number one, the LCX artery and the left upper pulmonary vein. So we have to take care of these two things. The four-chamber approach in the transesophageal approach is absolutely necessary to measure the height of the puncture, because generally it is done within the 2 to 2.5 millimeter of the crux. That means the mitral or tricuspid crux anatomy. If I go higher, then I may be able to reach the wire, but the sheath will be kinked. And when I push the device, be it a Watchman, be it an ampulager, then suppose it may be impinged into the lobe, but it may not be retracted again. So this kind of situations may not close the left atrial appendage properly. So the absolute height where the left intra-atrial septum is to be punctured is necessary, and it is to be done within 2 to 2.5 centimeter from the cracks. If we put it higher, it may be we may not be comfortable to reach the left atrial appendage. If we do it lower, it may hinge in the other pulmonary veins also. So another view, starting from the 90 to 0 degree to 120 to 135 in the mid-esophageal approach, generally gives us the right data of the left atrial appendage anatomy, whether it is chicken wing, whether it is cactus, or whether the some other anatomies, and the lobe is important, because I have put a ampulager device in a small lobe and there is another large lobe sitting in beside, it may not be occluded properly. So the lobe evaluation as well as the anatomy evaluation is important, and this is to be done in the 120 to 135 degree mid-esophageal approach. Now, coming back again to the interatrial septum, generally the puncture is done in the bicaval view. We all are familiar with the bicaval view. It is a mid-esophageal 90 degree with a slight right turn. It is being done. In the bicaval view, generally we can see the IVC and SBC simultaneously with both the atrium, starting from the left atrium to the right atrium. And in the bicaval view as well as the 0 degree and the 45 degree view, we can evaluate where to puncture, and the indentation of that needle is generally easily visualized in the bicaval view. So the anteroposterior approach as well as the inferior-superior approach is to be determined by these views. Now, the most important thing is the 0 degree and the 45 degree transesophageal view. In the 0 degree view, the left atrial appendage, the length from the left upper pulmonary vein can be evaluated, and generally it is released from the 10 to 12 millimeter until and unless the left atrial appendage is too large. If it is large, the length can be progressed to 10 to 15 millimeter also, and if it is carved in the ostium to the ridge, generally the length may be shorter also. So this 0 degree and 45 degree mid-esophageal evaluation is necessary to hinge, to release the device and to measure the length of the disc to the device. Now, the most important views which I shall be discussing for the puncture, it is the bicaval view and the short axis view of the transesophageal approach. So in the bicaval view, we can easily delineate the superior as well as the inferior, that is the SBC and the IVC. And generally it is being done closer to the IVC, that is the inferior rim closer. And in the short axis view, it is done in the posterior part of that. So with these two views, generally for the left atrial appendage closure puncture, we do it in the inferior and the posterior part. Now, the length is important, the site is important, the height is important, and the most important thing is the anatomy of the left atrium and the closer proximity of the L6 artery as well as the left upper pulmonary vein. And the puncture, as I have already discussed, is generally done in the 5 or 6 o'clock position. If the right atrial anatomy is larger, if the right atrial is quite big, you may rotate your needle, broken bow needle, to 6 or 7 o'clock position as well. So this is the slide which is showing that the optimal transseptal puncture sites of the left atrial appendage closure. The medial and posterior and the low transseptal puncture allows a straight approach to the left atrium. If we do it too high, the transseptal puncture more than 3.5 to 4 centimeter above the mitral valve plane.
Dr. Dutta, please sum up.
Yes, sure. So intracardiac echocardiography will help us in evaluating this kind of puncture as well. and the most important challenges we all should know that even if we puncture, we may not progress our sheath or the Moulin sheath because of the septal fibrosis, because of the lipomatous hypertrophy and these kind of situations. And in that case, we may use for advancement of the sheath, the coronary balloon or any other balloons you may use to progress the sheath if it is not crossing properly. Nowadays, the most important thing, the energy radio frequency transseptal kit is available, which is easier, which makes us easier to puncture as well as see the site of the puncture, as well as with the energy impulses, we can do it very easily without any damage to the nerve tissues. So these kind of recent advances in the septal puncture generally helps us to advance the guide wire also, and without injuring neither the left upper pulmonary vein or any other pulmonary vein or the left atrium, or there is minimal chances of causing tamponade as well. So the take-home message from today's topic is that transseptal puncture is absolutely necessary. Generally, TTE or transesophageal approach is necessary. Cardiac CT helps us in evaluating not only the lobes as well as the anatomy of the left atrial appendage. We must have a experienced hands for septal puncture, but generally over the time and the recent advances have helped us. And these two views, that is bicaval view, transesophageal, and the mid-esophageal short axis view, helps us in evaluating the anatomy. CT guided puncture may be to some extent needed, but generally echo is sufficient enough to reach our left atrial appendage, and the clot as well as the pericardial effusion before the procedures is the most two important things to be excluded. Thank you very much.
Thank you, Dr. Dutta. While choosing the amplager device or Watchman device, do you go for imaging in all cases, either CT or
no, not necessary. Not necessary, sir. Always not necessary. If I feel difficult in approaching the left atrial appendage, then I inject some kind of dyes like that. I have put a video also, sir. So generally after puncture, the needle straight away goes to the left upper pulmonary vein. It has to be dropped down again, and you can see the left atrial appendage. Then the wiring is being done, and you can slowly release the device. Once it's having an onion-like structure, the first lobe is released, then pull it back, and automatically the second flap is released. So it is easier if you are able to do all these things. So the anatomy evaluation is absolutely necessary, sir. And after the device placement, the one should exclude the damage of the left circumflex artery. So it is not recommended always, but it is safer to have a coronary angio done so that we are not damaging the circumflex artery or left upper pulmonary vein.
You mean angio after putting the device? Yeah,
I do angio after putting the device.
Thank you. Any question from the floor? Yeah, let me sit over. Thank you, Dr. Dutta, for your nice presentation. Thank you.
Thank you. Thank you.